Dr. Birhiray, I want to go back to the CNS discussion. So as we saw all the other drugs that we have, like if you look at the affinity, which yes, it's a study for pertuzumab, but it also included trastuzumab and chemotherapy, right? So for me, it's a dual HER2 direct antibody plus chemotherapy that showed no improvement in CNS recurrence. And we have the Catherine study with the ADC that also did not show. In fact, it was worse on the Catherine study. Is neratinib the only drug that can reduce CNS recurrence? Do we have this data from the ExteNET, and what can you tell us about it?
Yeah, so we have that data from ExteNET that shows that patients who got neratinib, if you go, so let's go to the patients that were who got the most benefit in ExteNET, which were the patients who were hormone receptor positive, who did not achieve a pathologic complete remission. If you were to just look at that subgroup, there was a 50% reduction in the likelihood of brain metastasis in that subset. So that's one bucket. If you look at the entire group, there is a reduction in the risk of brain metastasis. And it's not shocking, because when you look at data, right, you have to ask yourself, why am I seeing this data? If it doesn't make scientific sense, then you have to question the data even a little bit more. But the reason why I say it's not shocking is that this is a drug that has a different mechanism of action. It works intracellularly. It's a small molecule. It's able to cross the blood-brain barrier that may not be possible, or maybe not as robustly, with the monoclonal antibodies. So it makes sense that this drug with a different mechanism of action would do that. At this point, this is the only drug that is approved. Lapatinib, which, as you know, was a similar drug, was tested in different trials, and the trials did not show an improvement. Tucatinib is being evaluated. We don't have that data. So at this moment, this is the only drug that we have that can do that for our patients.
Yeah. I think for me, the biggest telling point is when you look at the 5-year cumulative CNS recurrence and you stratify it by PASI-R status, in the patient who have residual disease, the chance of getting CNS recurrence was less than 1% after neratinib. And I can't help but think about the Catherine study at that point. 7%, less than 1%. Like the 7 less than 1, 7 less than, I mean, for me, this is like a screaming data, right? Screaming data about the importance of using neratinib. And on the other side also, the PASI-R patients, I mean, there was 0 reported CNS recurrences on the patient who received neratinib. There was no report of CNS recurrence. And that's another thing that's also big, you know, like, even if you got 1, you'll be like, okay, it happened. But there was 0. 0 speaks volume, having no CNS recurrences. So definitely we agree, neratinib is a very important drug to have as a tool for our patient.